is, quality ENT practice, having best uh, equipped setup, I would say, in our country. Thank you very much, boss, for being with us in this journey. And I could hear voice of Prakash Mukherjee just now.
Yeah, good morning, sir.
Good
Dr.
morning,
Satish.
sir. Good
Yeah, yeah.
morning. I came to
Um,
know you being in US. Have joined us.
yeah, I
So
don't want to miss any of the opportunity when you are there. And that's why I requested Farooq to give me the link. Though the timing is here, it's around 11 or night. So, but still, I will try to be as much as possible with you.
thank you. Thank you for your commitment, being there in midnight, joining
Yeah,
us. Pleasure to meet SP Singh sir here today. He is a legend in this region for ENT and trained so many ENT surgeons here. Thank you, sir, and all the delegates. It's a pleasure being with you today. So, like Farooq had mentioned, a lot of interesting cases lined up today for the surgical demonstration and discussion. The first one to begin with, the time was for the radiology to discuss. And this first case to begin with is an interesting one. So, few words about the radiology because I've seen a lot of junior colleagues here. This is most important part of the surgical exercise when we begin to have a complete three-dimensional anatomy in our mind of the area we are going to deal with. And that is how we get from the radiology. And the radiology of choice for the non-inflammatory diseases of the paranasal sinuses or the inflammatory diseases of the paranasal sinuses is the CT scan, which gives us excellent bony anatomy. What we all in the paranasal sinuses is simply a bony labyrinth, which is surrounded by critical structures all around, sometimes with some millimetric distance. It is so critical to deal with those areas in the periphery. And CT gives us a complete three-dimensional map, like a Google map, in some millimetric distance where we are going to deal with. So the first onus on the surgeon falls upon what kind of CT scan do we order. See, if you write simply a CT scan PNS, radiologist will do in a couple of seconds with thick sections, 5 millimeter, 4 millimeter in coronal, whatever view, unless you ask some specific things. So they can finish in couple of seconds and give you a printout. To me, that contains no value. See, as I mentioned, paranasal sinuses are surrounded by important structures all around. We need to have a dynamic information of the surroundings as well as the cellular details of the paranasal sinus labyrinth because the cellular details in every individual is different. So we need to know exactly for that individual patient which we are going to operate what kind of anatomy that patient is having. For that, the first onus to order a CT scan and what simply we can order as a some millimeter. You can see on the screen. I hope the screen is there on your view. See on the left lower corner, it is 0.6 mm sections. CTs for the PNS is always shot in the coronal in the axial plane. We can just ask for CT PNS 0.6 mm sections. That's it. Don't need to write anything else. Yes, you can add on both in bony as well as soft tissue windows. And then with your own software, the DICOM, you can reconstruct and get the dynamic anatomy detail. Let me show you, first of all, what kind of dynamic anatomy we can get. See, this is axial section, and this every time I click, I move by 0.6 millimeter so that I don't miss any structures more than 0.6 millimeter in dimension to view when the image changes. See this? This is axial view. Now, there are certain information which is given best in the axial view. Certain information is provided best by the coronal sections and certain by the sagittal. So, it is again on the onus on the part of the surgeon to explore each and every anatomy best visible in that particular section so as to get a complete three-dimensional dynamic information. Now let me reconstruct to all planes. The same axial section which we got from the radiologist reconstructed to all planes. And this is such an amazing teaching, tool for the students that you can corroborate each and every finding on this software in all planes. For example, this is an intersinus septal cell. See this in the midline, and you can easily bring your cross hatch and see where exactly the intersinus septal cell seal in axial and sagittal planes. See, these are nasal bones here. You can see in all planes where exactly the nasal bones are there and how it is related to the paranasal sinus labyrinth. How anterior they are, you can see in the sagittal and the axial plane. Where the frontal sinus is, you can see where the frontal sinus is, and you can correlate in all the three planes. So this is an amazing teaching tool for the students to understand three-dimensional CT scan anatomy. Number one. Now, secondly, certain structures are seen better in the soft tissue windows, like surrounding soft tissue. See the infratemporal fossa muscles and surrounding areas, surrounding fat, the orbital details. See the interior of the orbit is completely, best seen on CT scan on axial plane, and that too on the soft tissue windows. Soft tissue windows will give you fine details of the soft tissue anatomy as well beside the bony anatomy. And see in the, as far as the pathology is concerned for this particular patient, see in the sinuses, we can see heterogeneous hyperdensities that is most likely suggestive of a fungal disease. So that you can pick up on a soft tissue window. So ideally for a CT scan, we need to have both bone and soft tissue windows to get complete information. That too again you can reconstruct in three planes, and you can have a three-dimensional imaging of every information you have on the CD, on the DICOM. See this? This is heterogeneous densities in the frontal sinus. You can see the fungal material in the frontal sinus everywhere. That is how you can get. So, bottom line is we have to order CT scan properly, order some millimetric section what the machine can give for the particular radiologist, ask for 0.5 mm, 0.6 mm sections in DICOM format, and then you reconstruct. You can download this software from the Google and you can run on your own computer. So this is the way you can get dynamic information. Now, the value of dynamic information and seeing the CT scan yourself, analyzing or observing or reporting CT scan. Now, what is dynamic? What does a dynamic CT mean? You can follow each and every anatomy on your own. Like for example, in this patient, as I mentioned in the beginning about the intersinus septal cell. See, when you begin from most anteriorly, what you see the frontal sinus. You can see the frontal sinus on this side opacified and the opposite side absolutely normal. This is the intersinus septum cell most likely which is deflected on the left side. This is soft tissue window. Let me show you on the bone window a little better. See this. Now you can say this bone very clear, intersinus septal cell. This is the most anterior aspect of the CT scan what we are looking at. See the most anterior picture. This is the frontal bone, frontal sinus on this side, and this is intersinus septum. This is a nasal, cartilages below. Now, as we go behind, what we come into picture, this is the nasal bones. We have seen just now before. This is the nasal bones on two sides and the internasal suture. Now, as far as the cellularity in the paranasal sinuses is concerned, the most anterior cells When you go from anterior to posterior, the most anterior cell you will come across are the intersinus septal cells. This is always same. The most anterior cell what you come across is the intersinus septal cell. Now for the intersinus septal cell, they communicate to either of the frontal sinuses. So how to know? That is the value of dynamic CT scan. That's what I was going to tell you. Now see, coming from anterior to posterior, keep an eye on the intersinus septal cell. See how big the intersinus septal cell is. What has this intersinus septal cell has done? It has pushed the frontal sinus opening, the frontal sinus outflow far laterally. See this? See this intersinus septal cell so big and it pushes the frontal sinus outflow far laterally. Today, Dr. Farooq has lined up today and tomorrow number of sinus surgery cases. And he asked me several times to keep this time, the theme on sinus surgery, showing variety of cases, not one or two, so that we can get idea of variety of cellular situation and how to deal with that. So this the first case being so interesting. See this how big the intersinus septal cell. Now in dynamic CT will tell you how it is communicating with the frontal sinus outflow on the right side, not to the left side. So the dynamic CT will tell you where exactly it is opening into the frontal sinus. See, and this is your frontal sinus. This is your frontal sinus, and this frontal sinus is draining through the frontal recess into the frontal recess here. So this intersinus septal cell is communicating to the right side, and this is best seen on a dynamic CT. So the second important thing besides ordinary CT scan, what we get from getting in DICOM is to have dynamic information. And third important is the complete information. That is most important. When your patient comes with a printout with one or two printouts, you can get 10 or 20, 30, 40, 60, whatever number of slides. Now imagine to have complete details in all planes. How many slides you need? On this CTs, can you see? Here on see 168 slides here, 168 here, bone and soft tissue. That amounts to 336. 336 in axial, coronal and sagittal. More than 1,000 slices. And even if you get a printout of more than 1,000 slices, it is number one so impractical, so cumbersome to carry 1,068 whatever slices printout, number one. And number two, to see them for a surgeon to see all those printout, which is so difficult or rather impossible to correlate. And third thing that is most important, that it is not going to be dynamic. So simply you can get this information on a pen drive or CD and you can run on your computer with complete dynamic information, and that is the ideal way to see the CT scan for that particular patient. Now, as I said, what happens sometimes in a practice, and you feel sometimes sad also when patient comes to you with classical symptoms of sinusitis, classical endoscopic picture of polyposis, with undoubtedly clear diagnosis, with a one or two printout of CT scan in hand. And, we have to order another CT scan to subject the patient to radiation again. So it should be like something for all of us to adopt a policy to order the CT scan in DICOM, so as it is never required to be repeated, never required a patient to be subjected to a radiation again. CT is radiation as contrast to MRI. In contrast to MRI, CT gives bony details, MRI gives soft tissue details. So in paranasal sinus inflammatory disease, CT is number one choice. For other tumors and other things and other skull base and other pathologies, the MRI is the choice of investigation you order. So once it comes to order a CT scan, it should be a generalized policy, and we should start adopting that we should order in a DICOM format. Now, as I said, there are certain information which are given best in the coronal plane. And coronal plane is easier to understand by the surgeon as well. To interpret the findings, it is easier by surgeon as we get the same information in the same plane in which we operate. This gives you the information in the same plane in which we operate the patient. So, to begin with, we must extrapolate as much as information we can get from the coronal CT scan, and then we can reconstruct into other planes and see whatever best is visualized in the axial and sagittal plane. So, quickly, in this patient is a right-sided, you can see, complete opacification with right-sided intersinus septal cell. This is bone window. We have seen on the soft tissue windows some heterogeneous opacity suggesting fungal material. Now, as we go behind, see, this is frontal sinus. The beak is there. If I reconstruct to coronal, what I mean to say by beak, see, we come in the nose from here with endoscope. And frontal sinus is strategically situated like this, anterior-superiorly. And this is the thick beak, which forms the floor of the frontal sinus. See this beak? When we come from anterior to posterior, our beak comes. Now imagine, you follow the beak, where the beak ends. Where the beak ends is the frontal sinus drainage. So simple. And this is what we are going to exploit in surgical session as well. When we operate, this is going to be one of the, best and the reliable landmark for the frontal sinus to identify and treat frontal sinus is follow the beak. Beak is a thick bone, I would say thickest bone in this region. You can easily feel, you can palpate and follow it. Where the beak ends is the frontal sinus outflow. As simple as that. So, in coronal, like if I come from anterior to posterior, see the anterior most are the nasal bones. Then I go behind it the beak. Now, as long as beak is there, above is the frontal sinus. As long as beak is there, above is the frontal sinus. Now, as I go behind, see now the beak is ending. These are the frontonasal processes. Now the beak is ending and see what is this. This is the frontal recess. Now what you see in the picture is the frontal recess, not the frontal sinus. How can you differentiate? Let me go back. See what is this? See, this is intersinus septum. Sinus with the floor. Now, the sinus is ending. See, the frontal recess is coming, which is formed by the ethmoids. And see in the middle, this is the cribriform plate with the crista galli above. So now, the things have drastically changed as we go behind. This is anterior, this is beak. As I go behind, the beak is ending and the cribriform starting, and this is the beginning of the ethmoids. So this is the beginning of the ethmoids here, and this is no more the frontal sinus now. This is structure which is behind the frontal sinus. We have left the frontal sinus anteriorly. See, let me go back anteriorly. This is anterior. Now this is proper frontal sinus. I am going behind the cribriform plate coming into the picture. We have left the frontal behind, and this structure looking like a frontal sinus is not exactly the frontal sinus. This is now the supraorbital recess. Can you see? Hello, am I audible?
Yes, very much.
Yeah. So feel free to interrupt me anytime. So now this structure looking like frontal sinus is actually the supraorbital recess. I hope it is very clear. Now, let me reconstruct in all planes and see what I was saying. The anteriorly is frontal sinus and posteriorly is supraorbital recess. Mhm. Mhm. Let me reconstruct and show you. Yes. So this is frontal sinus. Now, as I go behind, now this is frontal recess. See now, anterior to posterior, see in the sagittal plane. Look in the sagittal plane now. Anteriorly, this frontonasal process, the nasal bones, then is the beak, then is the frontal sinus, and then behind the frontal sinus, here behind the frontal sinus is the frontal recess. That is the frontal sinus outflow. See where the frontal sinus outflow is. That is the frontal sinus outflow. And behind that, this is the beginning of the cribriform plate. That is the level from anterior to posterior. This is the level where the frontal sinus ends and this cribriform plate begins. Look at the sagittal plane.
Yes, very
This is
clear.
the area where the cribriform plate begins. So anterior to posterior, we need to understand where exactly we are going. And that is seen best on the axial section here. And you can corroborate with the sagittal section. Now, as we go behind, see now, this was the beginning of the frontal recess outflow. That is supraorbital recess. See, this is orbit. This is orbit. You can see the normal orbit on the opposite side. And this supraorbital recess is encroaching above the orbit. This
Yes.
pneumatization is sometimes even beyond this. This
Yes.
goes and
Yes.
goes beyond and can pneumatize this bone, the orbital plate, the part of the frontal bone here. This can pneumatize this bone more and more. And we have seen this pneumatization even far laterally, even up to the zygoma.
Yes.
So this pneumatization of the orbital plate of the frontal bone above the orbit, see, this is supraorbital recess, and this anatomy is behind the level of the frontal sinus. We have left the frontal sinus far anteriorly now. And see, again I am going back. This is true frontal sinus. As long as frontal sinus is there, we don't see maxillary sinus. Can you see?
Yes. Yes. Yes.
Now I am going, this is frontal recess coming. And see below the appearance of the maxillary sinus.
Yes.
So once you see the maxillary sinus in picture with the structure looking like frontal sinus, it cannot be frontal. It is
Yes.
frontal
Agreed.
recess
Yes.
because we are far behind now. We are far behind to have seen the frontal, the maxillary sinus in view. So this cannot be frontal sinus. This is simply maxillary, the ethmoidal sinus, and this is supraorbital recess going above the orbit. And see, it is indenting on the orbit. Sometimes it can lead to, because of
Expanding
the
it
obstruction,
also.
mucoceles here, and we have seen segregated, sequestered mucoceles in the superolateral part of the orbit, many a times. So this is supraorbital recess.
Hello. Hello, Dr. Satish. Hello. Hello. आवाज नहीं आ रही. Hello, Dr. Satish.
Yes, boss. Can you hear me?
Yes. So how will you differentiate? How we can differentiate between supraorbital recess and supraorbital cell? There are
Supra.
some
Yeah.
or there is supraorbital cell sometimes, na. So
Yeah.
how
See,
we
if
should
it is a
differentiate?
shallow, if it is a shallow recess like this on the opposite side, see this?
Yes. Yes.
Once it is not very pneumatized, you can simply call it as a supraorbital recess.
Okay.
And once it is extensively pneumatized, we call it as a supraorbital cell or supraorbital pneumatization, whatever. It's terminology. But recess is a shallow one
Okay.
when it is not extensively pneumatized. Now, we have seen this is beginning of the cribriform plate here now. See this as I go behind?
Yes.
Every movement brings me 0.6 mm behind.
Okay.
And see here on down here, this is 0.3 mm now.
Yes. 0.3 cut.
You can't miss any structure more than 0.3 mm in dimension. Now, as you go behind, see, this is expanded because it is full of disease on this side as compared to the opposite side. Can you
Yes.
see?
Yes. Yes. Very
Opposite
clear.
is opposite is characteristically normal. You can see all the way, and
Yes.
that is classical of allergic fungal sinus
Understand.
disease. Allergic fungal sinusitis is characteristically found in younger people. This is a 12-year-old patient, 12-year-old, unilateral with heterogeneous hyperdensities on CT scan. You can see that is good enough to, suspect allergic fungal rhinosinusitis. Now, as we go behind, you can see the configuration of the cribriform plate now better. That's the
Yes. Very
horizontal
clear.
lamella, that's the
This is
vertical
the
lamella.
vertical.
Vertical lamella, see, forming the roof here,
Yes.
skull base, and you have to be careful at that point. Now, see how it is ballooning because of the mass effect, because of the fungus within and the polyps, how it is ballooning on compressing on the septum on the opposite side, septum to opposite side, and giving a DNS. Can you see the
Yes. Very
severe
clear.
deflection of the septum because of the mass effect? You can see here. Now, having seen all this coming from all the way anterior to posterior, we have not seen anything like any idea of anterethmoidal artery so far.
Yes.
Reason
Yes. Yes.
being, this is to shatter the fear of everybody.
Now, yes. Now there is
See this?
appearance of.
Yes, I'm
Yes.
going
Yes.
back. See,
Right.
going back to show everybody how far that anterethmoidal artery courses from orbit to the skull base. See this? Going anterior to posterior. Now going posterior, cribriform plate, cribriform plate. My focus is on cribriform plate, cribriform plate, cribriform. See how posteriorly I'm going. The
Yes. Yes.
bottom line is you don't have to worry when you work anteriorly in the ethmoidal roof. Now see, as we go behind on the opposite side.
Yes.
See this?
Yes.
On the
Yes. Very
opposite
clear.
side where you can see where the anatomy is not distorted, the beaking
Anterethmoidal.
of the medial wall of the orbit. Beaking of the medial wall of the orbit, and this orbitocranial canal leading to anterethmoidal artery and nerve to this through this lateral lamella, which is the thinnest part of the skull base here, into the olfactory fossa. So this is the point where the anterethmoidal artery is passing.
Enters.
Now compare to the opposite side. Compare this level to the opposite side. Suppose let me put it here at the same plane. Can you see?
Yes.
In the same plane of the opposite side here, my level of the artery is here, and see how much of the pneumatization and the disease superior to the level of the anterethmoidal artery between the artery and the skull base. Can you imagine?
Yes. Yes. Yes.
So this artery on this side is intermingled in the disease process. It is lying in the mesentery, and it is lying far low below the level of the skull base. See this?
Yes. Very clear.
On this side, the artery is definitely running in the mesentery, definitely much, much below the level of the skull base, and that can be a challenge, and you have to be careful. Got my
Yeah.
point?
Yes.
There
Yes.
cannot
Very
be a
clear.
better situation to deal with anterethmoidal artery than this in a sinusitis condition. On this side, it is running in the bony mesentery. Here, you don't even see any bone. All soft tissues, which is not visible, like an opacity only. The disease, artery, all looking like a similar soft tissue. You cannot discriminate here. And now, surgically, you have to be careful to prevent, damage to the anterethmoidal artery. If required, to coagulate, we will coagulate in a planned way. The fear. What is the fear here when we deal with the anterethmoidal artery? See this. This artery leaves the orbit from here. If this happens to get transected completely close to the orbital exit, it can retract into the orbit and can lead to
Interorbital hemorrhage.
intraorbital hematoma.
Yeah.
Intraorbital hematoma is something like an emergency you need to deal with to prevent permanent visual loss. It has a potential to give permanent visual loss. if it is not dealt with immediately. So, if this artery happens to retract into the orbit, it can keep bleeding inside. And since the orbit is a bony compartment from all around, it cannot accommodate more than 5 ml of extra blood. And if this artery keeps bleeding, can the pressure can compress on the optic nerve and the vessel supplying the optic nerve and can lead to visual loss. So, you have to be careful while dealing the disease on the side close to the orbit. You don't need to be close to the orbit. Pack mat karna, Ramesh. You need not to be, or you must not to be close to the orbit while dealing with. In case you deal with the artery in the middle of the course here and happen to transact, doesn't matter. You pick
Yeah.
your bipolar and coagulate. That's it.
Yes.
But you have to be careful close to the lateral. That is what I am going to show you in this particular case when we get the anterethmoidal artery. Okay. So this anterethmoidal artery, the bottom line is it crosses the anterethmoidal roof most posteriorly. Most posteriorly. See this. The moment I go behind this, the anterethmoidal roof has gone and the postethmoidal roof has started. Can you see? What I am trying to say again, let me show you. This was the artery here. See this? This was the artery here on the left side. Now, as I go behind this level, see now the anterethmoidal roof has gone and the postethmoidal roof has started. Just before that was the cribriform plate. Can you see here?
Yes. Yes. Very clear.
Yeah.
Immediately after that, the cribriform has gone. That means that artery runs to the posterior most part of the anterethmoidal roof. And immediately after that, in few millimeters, the postethmoidal roof starts. Can you see? That is the level of beaking of the artery on this side. This side. You see here? And this is the cell above. See this? On this side.
Cell.
Yes. Now, as you go behind, now the postethmoidal roof starts. See this disease on the right side, expanding the entire postethmoidal compartment.
Yes. Very clear.
On the opposite side, there's a normal postethmoidal cells, though they are bigger than the anterethmoidal cell. See, such a big cell in the postethmoid. As you go behind, this is all postethmoidal roof. See this? The thick
Yes, yes.
postethmoidal roof as compared to the anterethmoidal roof. And because of this thickness, the postethmoidal artery which runs through the postethmoidal roof, we rarely see prominent or we rarely see in mesentery. Because the roof of the postethmoid is normally relatively thicker.
Yes. Very, very, very thick.
Now, the most important part will come in surgery when you work in the postethmoid, as you need to have complete, picture in your mind of transition from postethmoid to sphenoid. So, how to differentiate when that you cross the postethmoid and enter in the sphenoid sinus? Because if you are not very sure, if you are not oriented and accidentally enter into the sphenoid, since the sphenoid has a lot of critical structures running in the walls, you can damage if you are not oriented that you are in the sphenoid. So, you have to be very careful and should exactly know where, when you are working in the postethmoid, that you have not crossed the limits. So, how do you see on CT scan? I will show surgically some catch points, but how do you see on CT scan which is postethmoid, which is now the sphenoid coming? See this bone in the roof? This bone in the roof all the way from pterion to pterion. This is frontal bone. Frontal bone forms the roof of the ethmoids. See this frontal bone forming the roof of the postethmoid. Can you see here?
Yeah.
Now, I am going behind. Now I am going behind. See what is this? The frontal bone is gone. It has left.
It's a sphenoid bone.
Yeah, it's a tilted picture. And see now, what is this bone which has come? This is
Sphenoid.
lesser wing of sphenoid.
That is lesser.
So this is sphenoid. This is not complete from pterion to pterion. Now, once the frontal bone is left and this bone has come, whatever sinus below is the sphenoid sinus.
Sphenoid sinus.
See, this is the rostrum here.
Yes.
This is the,
Yeah.
intersphenoid septum, never in the midline. And there is a very, very
No, no.
interesting situation in this
Yes,
particular
yes, yes,
patient.
very
Can you
interesting.
see this cell in the cell?
Yes, yes,
So
yes,
this inside cell, whatever we are seeing, is the postsigmoidal cell.
yes, sonodal
And
cell.
see, whatever sphenoid is, it is pushed behind and it has become very small on the right side. Why? Why? Because see this. This is postsigmoidal disease. Can you see?
Yes,
See the continuation of the postsigmoidal disease. The postsigmoidal cell is ballooning because of the mass effect and going inside the sphenoid. Can you see this?
yes, 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 yes,
So this is postsigmoidal cell in continuity. See, this is postsigmoidal cell anteriorly, and follow
yes,
this cell. Follow this cell. This is postsigmoidal cell, and the sphenoid is there around. Can you see very
yes,
clear?
yes, yes, very
Yeah.
clear.
This cannot be seen on printout. Imagine, boss, you see this kind of CT scan on a printout given to you. This cannot be correlated so well dynamically, and one can, if you don't realize what is sphenoid, what is postsigmoid, one can, is likely to give injury to the surrounding if it is disoriented. So this dynamic CT is so important. Now, at this point of time, let me reconstruct all three planes to show you what I'm trying to say, the difference between postsigmoidal cell and sphenoid. See this? What I'm trying to say, this is the postsigmoidal cell. Can you see?
Yeah,
See,
much expanded.
see on the sagittal. This is postsigmoidal cell, which is pushed beyond the anterior wall of the sphenoid sinus. See this?
Yes, 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 very clear.
Can you see this postsigmoidal cell?
Yes,
And
Yeah.
push the sphenoid to a smaller size. Can you see?
yes,
See
yes,
this? On the axial also you can see. See this postsigmoidal cell which is pushed so behind on this side because of the mass effect, because of the disease inside. Compared to the opposite side on the axial plane, see how important it is. This is the level of the anterior wall of the sphenoid on the opposite side. Can you
yes,
see?
yes,
Yeah.
very clear.
See the level of the anterior wall of the sphenoid on this side. See the difference. This is the level of the anterior wall of the sphenoid on this side. Can you see this? And see here the level of the anterior wall of the sphenoid at this level.
Yeah.
Because this is pushed by this postsigmoidal cell which is ballooning towards the sphenoid sinus. Is that clear?
Yes, very clear.
And
Yes.
sphenoid sinus is pushed to such a small sinus. See this?
Yes, yes,
Sphenoid is very small in this particular case. See this?
yes.
That's what I was showing on the. See this? This is the postsigmoidal cell, and this is sphenoid is a very small sinus behind.
Yes,
So you have to be very careful while working in the sphenoid sinus. Now, about there, on both sides are the impressions of the optic nerve. Can you see?
Yes. Yeah.
This opposite sphenoid is more pneumatized as compared to this sphenoid on the right side. And this sphenoid is pushed, whatever it was, by the disease postsigmoidal cell into the sphenoid sinus. The cell entering into another sinus beyond its territory. That's the important finding in this particular patient. So this was a basic, idea of the CT scan of this patient. Anything more if you want in detail, I can elaborate on
no,
any plane.
I think everything is clear now.
Because we have a number of cases of sinus surgery lined up. We'll see in every patient what different anatomies, what different pathologies, and accordingly we'll discuss. So our case is ready for the surgical part. If you say, we can go ahead. Or any questions we can take. Any questions, sir?
Any question? Any confusion? Hmm?
Hello, sir. Hello. Hello.
Yes, sir.
Sir, vital apex looks wider on the right side, sir. Is it
What?
so, or just an incidental finding? Or vital apex looks wider on the right side. Apex
Orbital
of the
apex.
orbit. Yes, sir.
Okay, let me go to the apex of the orbit first.
Yes, sir. This.
No, it is not wider. The image is tilted.
Oh, tilted, sir.
Aha. See this.
Oh,
This right side image is little posterior than the left side. See on the left side, see this frontal bone disappeared first on the left side
yes, sir.
Yeah.
and later on the right side.
Yes,
So
sir.
this is
Tilted.
little
Image is tilted.
tilted. The right side is coming little behind. So that is orbital apex.
Okay, sir. Thank you, sir.
It is not widened by any disease process or anything. And for that matter, in sinusitis, AFRS and all this, even if it affects the orbit or orbital apex, anything, it would rather push and narrow it because of the mass effect rather than widening it.
Okay, okay,
Widening
sir.
will happen when something goes inside the orbital apex and expand.
Yes, sir. Thank you, sir.
Now, these patients, as far as the preparation is concerned, see, we will discuss variety of sinusitis situations. Sinusitis in itself is a complete subject. There are variety of endotypes of sinusitis now discovered, and every endotype has a different underlying pathophysiological process. And this is one of the different endotype, that is allergic fungal rhinosinusitis. So let me wash up and start in a couple of minutes. We'll continue discussing.
Dr. Farooq, can you hear me?
Hello. Sir, Farooq sir is not there.
Okay, can somebody tell me how the patient presented? What was the clinical history by the time the Dr. Satish Jain starts?
Okay. I will tell someone, sir.
Yeah.
Hello.
Yeah, what was the clinical presentation in this case?
This patient had a nasal obstruction, discharge, and some headache also, what they have mentioned.
Right.
And on endoscopy, there is polyposis on the right, in the right nasal cavity.
Okay.
Now, what CTs can we discuss? We discussed with the radiologist earlier number of times and prepared a pro forma for them to give details of each and every point we want from our surgical perspective. So we prepared a detailed pro forma for the radiologist to fill in for everything, for all variety of cells, the kind of disease and kind of finding in each and every sinus for the radiologist to fill up. You know, it would take radiologists not less than 1.5 to 2 hours to fill that pro forma.
Yeah.
More than 400 points, and they straight away refused.
Yeah.
Radiologists can't afford to spare this much of time to fill up such a big pro forma. So again, the onus is on the surgeon to understand how to read the CT scan and interpret that. From surgical perspective.
I think, Dr. Satish, everybody will agree with you. Interpreting your own CT gives you a better view because radiologist is just concerned with a broad pathology, whereas we as a surgeon have to see nook and corner and all the detailed structure of it.
Exactly, sir. So most of the time the radiologist is blinded with the clinical details
Right.
and they just behave like a clinician, technician to report whatever it is seen on the
Right.
pictures.
Yeah.
So finally, again from the surgical perspective, are you getting the endonasal picture, sir?
Hello.
Yes.
Yes,
Are you
sir.
getting the endoscopic picture?
Yes, sir. We are getting.
Yeah.
Sir.
Yeah.
So this is the primary picture without decongestion or anything. And what I am doing, the initial preparation. See my initial preparation, I am using this marrow cell. We have cut marrow cell into 7 or 8 pieces and soaked in saline adrenaline to apply topically. See, just I am trying to apply the saline adrenaline on the mucosal surface. That's it.
Have you
Yeah.
have you done any dilution?
Yes, this is 1:2.
Okay.
Because this is young patient.
Okay.
In elderly, we can do 1:4 or even more diluted. But in young, we can use even pure topical as well. 1:1000.
But
without dilution.
earlier you don't use to dilute. I think
Yes.
earlier you
So
don't use to dilute.
this young patient 1:2 is hardly anything. But many a times in young patient, we use directly undiluted 1:1000. Because the moment you apply on the mucosal surface, the vasoconstriction prevents its systemic absorption immediately.
Yeah.
So it is pretty safe. The topical application is very, very
Very
safe.
safe.
This is very, very important for the surgeon, this kind of preparation. Why we are focusing on the preparation? And this preparation is just the intraoperative part. Our preparation should begin days or weeks before surgery rather. The idea is to bring the mucosal condition back to normal to deal with this inflammation, ongoing inflammation of the disease to the mucosa, which otherwise bleeds a lot in the inflammatory condition.
But the
So-
response, hello Satish, but the
Yeah.
response of a steroid is so big that most
Yes.
of the polyp disappears most of the
Yes.
time and patient doesn't turn up for surgery.
No, you see, you may have this concern, but you have to tell your patient, prepare accordingly. See that you can operate him right now, but this is not a good situation for the patient's perspective, as it is going to bleed a lot. And in that bleeding, if the ongoing bleeding is too much, it is difficult to identify the landmarks and the chances of complications are more. So we will give some medical treatment to make you absolutely inflammation free, and that will be the optimum condition for surgery. And patient, you have to tell patient that you may feel like not getting operated, but that will be the ideal time to operate upon. So it is the counseling which matters. See this, what I am doing, just topical application on the mucosal surfaces. This is my intraoperative preparation. Pre-operative preparation, like Ashwini boss said, should be to reduce the inflammation steroid. See, this is inflammatory disease, not infective disease. And polyp is a T helper cell 2 mediated inflammation, purely eosinophilic inflammation, which requires steroid as a tool to reduce inflammation. Steroid is the only way to reduce inflammation in these patients. So that's why the oral steroids work like anything to reduce the inflammation and overall bleeding. The goal is to make the surgical conditions perfect by means of reducing the intraoperative bleeding. Secondly, intraoperatively, what I am doing is one aspect. Applying the adrenaline topical to the whatever mucosal surface I see. Rest is done by my anesthesiologist, where I expect the heart rate to be lower, below 70. It was, So our
Is there
anesthetist
is there any relation of resting pulse rate and with the operative pulse rate?
yes. See,
Because they
what I
don't
mean to
agree for
say-
reduction of less than 1/3, more than 1/3.
what I mean to say is if the pulse rate is low or below 60, whatever, around 60, the overall cardiac output would be less.
Yes.
and the overall bleeding will be less, the capillary bleeding. Because this, in sinus surgery, is what you come across the bleeding is capillary bleeding, not the arterial bleeding.
Yes, yes, yes.
Not like tumors. We have a JNA case tomorrow. There you will see the arteries feeding the tumor.
Yes. Okay.
This is capillary bleeding, and to reduce the capillary bleeding, the cardiac output is the key factor. Number one. It doesn't mean that you operate in the hypertensive situation. You can operate in the normotensive situation with a good field, with keeping the cardiac output towards the lower side. So that is one of the protocols. Another is, that is again the anesthetist prerogative, what kind of anesthesia they use to prevent vasodilatation. Vasodilatation will invite more capillary bleeding.
Yes.
So, worldwide, there has been a consensus on using the TIVA, total intravenous anesthesia. The beauty is you can manipulate the conditions much better, preventing vasodilatation, using low, acting beta blockers and all that. They use remifentanil and esmolol and other things with all those in the TIVA. But in our countries, many of these things are not available. And you see, a lot of people use sevoflurane, a lot of people use propofol, a lot of people use clonidine. There are many ways to, bring to the same condition. So that is the anesthetist prerogative to get you the best operative condition with least bleeding and less vasodilatation. So can you see the change in the picture now?
Yes, yes.
See the polyps? This cavity is roomy as compared to the other one we have seen because of the DNS and because of the mass effect. The DNS is because of the mass effect, but we are not going to operate on the opposite side at all. This is a strictly unilateral disease, and this disease, as I said, there are a lot of endotypes of the sinusitis. This endotype is different from others. This is purely type 1 hypersensitivity to the fungal antigen to this patient. So, a fungus, we all know, is ubiquitous in air. Whenever we inhale a lot of fungus, and that is expelled by the ciliary activity, mucociliary activity into the nasopharynx and then to the gut and expelled. In patients who are allergic to that particular fungus, if that fungus happens to get entrapped and pushed in the sinuses, can invite the eosinophilic reaction and lead to this kind of a picture. So this is pure type 1 hypersensitivity to the fungal material. And for any hypersensitivity, anywhere in the body, the treatment of choice is steroid. And that's how for this condition also, the treatment of choice is steroid. But see, how can you give oral steroid for longer period?
How much? How long? How long do you prescribe
See, the
steroids?
hypersensitivity is lifetime unless you treat that underlying condition, which is difficult. So you give oral steroid, patient will respond like anything, but in your hearts, the adverse effects of the oral steroids for long run. So you can't give oral steroids in long run, and you have to switch to the topical steroids. And here the surgery has multiple roles in this particular situation. Number one, to remove that fungal material, the antigen, which is inciting this eosinophilic reaction. You will see when we open the sinuses, the fungal eosinophilic material. So we have to remove that antigen basically, which is inviting all this reaction, eosinophilic reaction. So the first goal is to remove the inflammatory load and the entire antigenic stimulation. And number two, to make the sinuses, the opening of the sinuses wide enough where the topical steroids can penetrate and avoid the need of oral steroids in the future. So that is the role of sinus surgery in this particular situation. Every endotype has a different underlying pathophysiology and you have to deal with that differently. And this is a different endotype, as I said, AFRS. Now, from the surgical perspective. See, the tool I am going to use now in my hand is the shaver, my geomet micro debrider. Can you see?
Yes, 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 very clear.
Chal, Neera.
So 0 degree blade, na?
Yeah, this is a straight tri-cut blade, 0 degree blade you can see. And I again congratulate Farooq for this wonderful setup, who has a all world-class equipments, the state-of-the-art Geomet micro debrider IPC system, the state-of-the-art Carl Zeiss Vario microscopes, state-of-the-art cobblator, and so many other gadgets here. See, now what I am doing is
Shaving.
under vision. See, follow your blade with your telescope so that whatever you see close up. You have to shave the polyps, not other structures. I hope the picture is good.
Very clear, very nice picture.
See the fungal material in between.
Yes.
Now, with this much of the massive disease, see this, the normal anatomy is distorted in the middle meatus. Normally, what you see here, you see the uncinate process, see the fungal material. See all this fungus. Huge. We have seen on CT scan everywhere what the fungus.
So this is which cell, anatomically, which cell you are dealing with?
You can't say, boss, right now because the entire anatomy is distorted. That's what I'm trying to say now. See what you have seen your middle turbinate. See this?
Yes, that is middle turbinate.
It's pushed medially towards the septum. Can you see?
Yes.
Septum is deviated, and because of this mass effect, the middle turbinate is pushed medially. See here, the most medial anatomy. Now, the uncinate process is one which is, distorted. Now, how to identify the uncinate? Let me tell you.
This is bulla, I think.
Yeah, this could be the bulla, which is, ballooned up due to the disease process. Can you see?
Yes, yes.
This most likely the bulla, and now I can see some anatomy coming up in my, which I am going to share with you.
Now uncinate can be delineated very easily,
Yes,
very clearly.
yes, because it is pushed. It is pushed laterally by the disease.
Yes.
The uncinate is pushed laterally by the disease. See that?
Yes.
Coming into picture, I will show you. And we have seen in this particular patient, the maxillary sinus is pretty clear. That is hardly affected. If I'm correct, I don't remember. But as far as I remember, the maxillary sinus was pretty clear in this patient. See, that was the bulla which was ballooning. See that?
Yes, yes, yes.
Ballooning, and the disease is ballooning the bulla, the frontal recess, and the supraorbital cell area, postethmoids, and further behind. Now, at this point, I will further again apply my Merocell to keep my field good. Topical Merocell you can repeatedly apply on the mucosal surface to improve your surgical. Hope the surgical field is good for you.
Yes, yes. What is blood pressure and pulse rate right now?
Blood pressure is 120 to 78. As I told you, that we are operating, always operate in normotensive conditions.
Okay.
And the heart
Normotensive.
rate or anesthetist is bringing down.
Okay. Presently it is?
Right now is in 90s, but he'll bring it down soon.
It has to be.
See, just apply. Never ever press this marrow cell hard on the mucosal surface.
Okay.
It will rather be counterproductive in giving venous congestion.
Okay. That another takeaway point. You don't have to apply
Just
pressure.
apply gently on the mucosal surface to apply adrenaline. You are not applying pressure. That is not our goal. See the field now. Second way is to
Irrigate.
keep irrigation in between. See the saline wash. I hope the picture is good now.
Excellent. Excellent. Picture is excellent.
So that now this is the uncinate process. Why I
Yes.
call it uncinate here?
Because
That's the only. See, this first prominence belongs to the nasolacrimal system.
yes.
See, this is fixed anatomy. And this is the mobile structure. Can you see?
Yes, yes, very clear.
See, this is evoted because of the
Disease.
See, this is uncinate. That's the only mobile structure in the entire lateral nasal wall. That's the only mobile structure in the entire lateral nasal wall. And here, what I'm going to do is, I will do infundibulotomy. We call this step, what I'm going to do next is the infundibulotomy. Infundibulum is immediately lateral to the uncinate process. See this. For junior colleagues,
Yes.
this is uncinate. Behind the uncinate was a bulla, which is all distorted. In between them is a narrow slit-like space, hiatus semilunaris, which opens medially into a three-dimensional space, laterally into the three-dimensional space, that is infundibulum, into which the maxillary sinus ostium opens. So what I'm going to do is, I will bite through the uncinate to open up the infundibulum, and this uncinate is the anatomy of the uncinate is important to understand. This is the vertical part of the uncinate. See this? This goes up and forms the medial wall of the agar negi to go laterally further onto the lamina peparistia. That's the vertical part. That's the horizontal part. See, follow the horizontal part. This goes to a variable distance
Yes.
into the inferior turbinate or the perpendicular plate of the palatine bone.
Palatine bone.
So now I will just bite through the uncinate at the junction of vertical and horizontal part here. See this?
Yes, yes.
Turn your forceps down and bite through. Advance, further advance until you get the hard bone. See now I get the hard bone here. See this?
Yes, yes, yes.
Which I am not supposed to bite through. If I bite through the hard bone, I'll bite through the nasolacrimal system and that would be a disaster. So when you use the reverse biting, you have to be very, very careful. This feel, that is the feel, palpation, the feel of the forceps when you bite through that, it is not biting through the nasolacrimal system. Now at this point, see what I have done, they created this window. This is the horizontal part of the uncinate. See below?
Yes, yes, very clear.
Fracture the horizontal uncinate. Fracture the horizontal uncinate. Gently, and create this middle meatal enterostomy. Can you see now?
Yes, yes.
Now, rest of this you can either remove with your shaver or you can use your through biting.
True, but
Sharp tools have value in sinus surgery in terms of mucosal preservation. See this?
yes.
And creating this middle meatal enterostomy. See this secretion? See this?
Yes, yes. Do you advocate this balloon sinus surgery?
Never, boss. That is, to me, to our concept, doesn't serve the purpose. Our purpose is to remove the inflammation and to give adequate, wide openings to penetrate the topical steroids in future. If that purpose is served by anything, you can go ahead. If that is not, that is useless. So that is my middle meatal enterostomy. What is it? See this? A simple middle meatal enterostomy. I told you the uncinate and the lateral wall here was pushed little laterally. See this? Because of this disease which was ballooning in the middle meatus. See this?
Yes, yes, yes. Very nice.
Interior of the maxillary sinus. We can anytime go back, or if you want later on, I will show on the CT scan the same finding, how the maxillary sinus was pretty clear and how this medial was pushed laterally. Now, having done this, the next step, this is the upper part of the uncinate. See the remnant.
Yes.
This is one of the most important anatomy now. Because
Yes.
this is again, we know the uncinate is pushed laterally. Pushed laterally means close to orbit. A laterally pushed uncinate means more closely placed to the orbit. What my point?
Yes. Very.
And at this point of time, what I'm trying to do, I am removing this upper part of the uncinate to reach to the lateral wall of the entire sinonasal corridor. That is orbit. Our lateral wall of the entire corridor is what? Orbit. See, when we make this entire sinonasal corridor, the lateral limit would be just irrigation. Yes. See this, the lateral limit of this entire corridor would be orbit.
Yes.
This upper part of the uncinate is the closest structure to the orbit,
Yes.
medial wall of the orbit. So while removing this uncinate, be careful under vision. And in this particular patient, when the uncinate is lateralized, it is more closely placed to the orbit. See that?
Yes.
The moment you remove, that is the medial wall.
Yes.
That is the lamina papricia. See there.
Yes. 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 Very clear.
So be careful at this step. Remove uncinate in toto, but at the same time be careful not to violate the medial wall of the orbit. If you happen to, for junior colleagues, it can be, a sort of depressing thing to get orbital entry at the beginning of the surgery. It can ruin your temperament, but
Nothing to worry.
you have to be able to
Manage it.
manage that. See that the medial wall of the orbit very clear?
Yes. Very clear.
You see the lamina very clear?
Yes.
And see how the upper part of the uncinate is so closely related to the lamina.
Yes.
See this?
Yes.
See, I am removing everything under vision. Uncovering the lamina completely. See that?
Yes. Yes.
That is the lamina. This looks like your Agarnici cell now.
Yes.
All distorted. That's why I'm saying looks like. That is your medial wall of the orbit. Very clear?
Yes. Very clear.
That is your maxillary sinus. This was your bulla, and above that bulla, that looks like your Agarnici.
Yes.
And see all
Yes,
this
yes,
fungal
discharge.
material. All this fungal
We-
material.
Yes. We will get very wide frontal opening there.
Yeah, already widened by the disease.
Yes. Indeed. Yes.
Already widened by the disease. After every step, just wait, give some time for the conditions to make the conditions better. See this. This is not wasting time. This is rather saving time, I would say.
He's
Not only
investing
saving time, but saving from complications also. See this. We have done this lower part. We have seen the orbit, the medial wall of the orbit.
Yes.
Now is the time to go up and see the frontal recess.
Yes.
And for that, I will take our favorite 70 degree. This is the ideal telescope, I would say.
Satish,
Yes, sir.
actually there are three types of 70-degree available with the stars. I know.
Mm.
One is sideway, another is downward, another is upward. Which one you
Upward
advocate?
is upward is the sinoscope, downward is the laryngoscope.
No, this is not laryngoscope.
Huh?
No. This is only for sinus surgery.
Yeah,
The
yeah.
light is from side. No,
Yeah,
one
yeah.
in the
I got your
light,
point.
but laryngoscope is different.
Yeah. So this 4 mm telescope, we should keep the upward pointing for the sinus surgery, I can say.
Yes, because in that we get now your instrument, it will not obstruct the instrument movement.
Yeah, your cable will not obstruct.
Yes, that is very big point.
Yes. So this is your 70 degree now. सोच का नहीं है है ही नहीं इसको. This is 70 degree here. Can you see? That is 70 degree. You see your medial wall of the orbit very clear now?
Yes, very clear.
Your middle turbinate very clear here.
Yes,
See, the medial turbinate is here, medially.
yes,
The bulla is below.
yes, and that is
Again, see everything. The beauty of the 70 degree is you get at this point above in the angle all the structures in one view. All the structures
Yes.
means your middle turbinate medially. See this?
yes,
And in the entire work of the frontal recess, I will keep this middle turbinate
intact.
intact as my medial limit. Got my point?
Yes.
During the
Because-
entire surgery, I will keep my lamina papyracea intact and in view as lateral limit. See this? I will stay between these two medial and lateral limit to go up into the frontal recess. Okay?
Yes.
Now, in order to go up in the frontal recess, I told you during radiology, the frontal recess comes when the beak ends. Beak forming the floor of the frontal sinus, when it ends, the frontal recess comes. Got my point?
Yes.
So, let me show you where the beak is.
Yes.
See, this is axilla.
It's the axilla of middle turbinate. Yes.
So, I am staying between this is the simplest way I am telling you to deal with the frontal sinus. Never get disheartened once you see the variety of frontal sinus situation. See this. What I am looking at, beak. See this.
Yes. Looking at the beak.
Can you see the thick bone?
Yes.
See the thick bone there up.
Now it's visible.
Let me clear it. And the bottom line is stay between medial and lateral limits. See, this is thick bone.
Yes.
This is your medial limit. This is your lateral limit.
Yes.
Got my point?
Yes.
Stay anteriorly close to the beak. When you stay close to the beak anteriorly, your anterior ethmoid is miles away. Miles away. That is far behind. See, stay close to the beak. See what I am saying? See this?
Yes. Now enter the frontal.
Stay close to the beak and where the beak ends. See this?
Frontal
Can you see
sinus.
this?
Yes.
That is your
Yes,
frontal.
frontals.
Now see what I have seen above. This is my frontal sinus. See that?
Yes.
This is
Very-
thick beak.
Hmm.
And this is the intersinus septal cell medially.
Yes.
In this particular patient, we know from our radiology. What my point? Now
Yes.
again, reorient yourself. This is my beak, which I have discovered. This is my lamina papyracea. Can you see? I have discovered. This is my middle turbinate. I have discovered. Now I
All the-
have to
all-
stay between these three landmarks and play whatever you want to. See
So,
this?
so all the landmarks of facial research are very clear.
Frontal recess. So if you stay between your limits, you can't cross them, you can't violate, and you can't give complications beyond. Say this. What? See now where the fungus is coming from?
Frontal sinus.
Frontal. Frontal is up there.
Yes. And inferior beneath the part of bulla.
Yeah, in bulla I have left below. We will see later, posteriorly, when we work around the anterethmoidal artery. So now, as far as I am working anteriorly, there is no question that the anterethmoidal artery anywhere being close to it. Because I am working in the anterior direction, anterethmoidal running in the posterior most part of the anterethmoidal root, far behind.
Yes, yes.
Don't get terrified from the beginning about the anterethmoidal artery. From this territory, it is miles away. See now the frontal becoming more and more clearer.
Yes, very clear.
In the simplest way, anybody in the auditorium can do this, keeping this 70-degree, keeping all the three landmarks in view. See this? Middle turbinate, lamina papracia, this is lamina, this is middle turbinate, and this is beak. Can you see?
Yes, sir.
And just see the frontal outflow, like Ashwini boss has mentioned, it is already going to be wide. See this, all fungal disease we saw on the soft tissue CT scan. See that? See, we are just following the CT scan.
Yes, sir.
This is all fungal disease. See
Will you,
this?
will you send it for histopathology, sir?
Yes, for academic purpose you can send. Otherwise, it is not going to make any
Typical of
difference.
fungal disease.
Yes, so that will fulfill your diagnostic criteria as showing the fungal stain positive. दूसरा वाला देना कैसा है 70 change the 70. See the interior of the frontal now. Hello.
Yes, sir. Now we are getting the picture, sir. Yes.
Here comes sometimes the role of hydrodebrider. You can wash off with a water jet more effectively.
That's a hydrodebrider, sir.
Yeah, I use hydrodebrider mostly for this purpose only.
Very sticky in nature.
Yeah, this is pure chocolate butter sauce. You can use a high power suction, you can flush. In between, you can debride to break, whatever. The various strategy. If you have hydrodebrider, you can remove in less than a minute. This is all fungus.
Yes, sir. Most of the disease has come out, sir.
Why it is still a lot of there. What is this medially?
It's interfrontal cell, sir.
Yes, that is intersinus septal cell. Remember on CT scan?
Yes, sir.
That is intersinus septal cell. See that?
Yes.
So intersinus septal cell narrows the frontal sinus outflow from medially. Side biter, frontal.
It is type 3, sir.
What is?
It is
No,
which
no,
type of
this
cell,
is-
sir?
This is intersinus septal cell. This is not frontal cell.
Okay, sir.
Frontal cells are different. Now I am flushing this cell. Oh. No. Let me wash. See, I am going to flush this cell
Yes, sir.
thoroughly here. See this?
Yes, sir.
See this still fungal debris coming out. See this?
Yes.
Clear?
Yes, sir. Clear, sir.
Now give the side biter. I am using see this the tool I am using is a side biter.
Yes, sir.
What a tool. What I am doing, communicating this.
Making a single cavity.
Yes. No other tool can work here. See this?
Sir, how it looks externally? That
Generally,
instrument.
there is trans illumination.
No, sir,
That
the
instrument.
instrument. Yes, sir.
I will show you. It's the true biting forceps working from sides.
Yes.
Ashwini boss will definitely like this. See this? It's a
Yeah.
frontal punch,
Yes,
but it's side biting.
okay, sir.
So you can communicate your septations, you know.
Yes, sir.
And now see how beautifully this frontal intersinus cell, sinus septal cell looks like. I'm communicated so wide to drain into the frontal sinus. You see now?
Yes, sir.
Is that clear?
Yes, sir. Very clear, sir.
Now, still our frontal has a lot of fungal disease.
Hello, Satish. There is another
Yes, boss.
septation. There is another septation lying above. Will you like also that one to connect?
If that obstructs our outflow, let's see.
Okay.
See this disease in the frontal. See there? See, that is scallopings. Can you see? Boss, those are scallopings which need not to be removed. See that? Everywhere scallopings. Can you
And
see?
that is, yes, that is scalloping.
And here, see behind, see that is anterior frontal sinus.
Hmm?
This behind here is the frontal recess.
ये तुम्हारा frontal sinus
Now see the picture. That is your intersinus septal cell medially. Can you see?
Yes, yes, very clear.
This is your frontal sinus.
Yes,
And
it was
behind
special.
here is going to be the frontal recess. See here going to be the frontal recess. Let me
Yes.
reverse. So let me uncover the frontal recess more. Supraorbital
Or
recess. Sorry.
supraorbital recess.
Yeah, let me uncover this supraorbital recess more.
वहीं पे दारू पी के पटना में।
See this? I am using my reverse forceps now. That is the adenoid blade. So-called adenoid blade. See the supraorbital recess now.
इधर क्या दाढ़ी का इस्तेमाल जो लीगली अलाउ है वो है। Actually, this is adenoid blade. Is
Yes.
it adenoid blade? Yes.
Yes,
But it is never
recommend
used for
adenoids.
adenoid surgery. But never use it for adenoid surgery as advocated by Satish Jain.
Yeah, because this is rear facing. It becomes front
Never
facing
use. Never use.
when you use here. Now see how the supraorbital recess is opened up.
Yes, excellent.
I am going with a 70-degree high up above the orbit.
Yes.
See this going above the orbit.
Yes, yes, yes.
This is above the orbit. This is orbital bone. This is above the orbit. That's the
So extensive.
supraorbital recess, the frontal sinus, and the intersinus septal cell. Can you see all three?
Yes, yes. It means supraorbital recess is always an extension of frontal sinus.
Yeah, it pushes the frontal sinus medially from laterally.
Okay.
It narrows the frontal outflow from laterally, and this intersinus cell, septal cell, narrows the frontal outflow from medially.
Okay.
And this supraorbital is posterior to the frontal sinus. See? It is always posterior to the frontal sinus. Let me completely uncover this because this is a huge recess. See how big would be the drainage pathway now and how big would be the pathway for penetration of local steroids also, topical steroid also. That is more important. Reverse. Reverse. See this?
Farooq, Dr. Farooq is there? Is there?
Yes, Farooq is there in the OT, boss.
No.
Boss?
Yes. Today we have not seen any blockage of your suction. That's why I am more interested.
Yeah.
You are, today there was no complaint of suction till now. For most of the time you will always complaining
That
of
is the
suction.
best thing. I always look in wherever I go for operating. The first thing I
Inquire
the
for the
suction.
suction. And that is the question, which suction he is using.
see now, the supraorbital recess completely flushed.
Yes, absolutely absolutely wonderful.
That is the beauty of the reverse blade. Now, still, see this. The entire
Yes.
centimeters wide opening we have made, and we have not uttered a single word, discussed a single thing about the anterethmoidal artery.
Yes.
Absolute fearlessly we have done.
Yes.
The reason
is-
is we are working far anteriorly, and I told you the anterothymoidal artery comes,
Behind the front.
runs through the posterior most part of the anterothymoidal roof.
Yes.
This is frontal.
Yes.
Supraorbital cell, frontal sinus, supraorbital cell laterally here, frontal sinus anteriorly here, and medially this intersinus septal cell. Everything clear.
Yes.
We must know when we deal with the frontal sinus, we must know the cellularity, the drainage pathway, and the orientation by a dynamic CT scan. Now see what we have seen below. That was the remnant of bulla. We didn't bother about the anterothymoidal artery as long as this bulla was intact. See this?
This is intact bulla technique.
Because my anterothymoidal artery is covered by this bulla
Yes.
from anteriorly. See, this is our maxillary sinus.
Yes.
With 70 degree, I am showing the interior of the maxillary sinus. See, this is absolutely perfect.
Absolutely perfect. Except.
See, this sinus is
Yes.
fine.
Yes.
That is the orbital surface. That is the lamina pepracia.
Yes.
And now, if I rotate, this is your bulla. See, we have done the entire frontal sinus work and didn't bother about the anterothymoidal artery at all.
Yes.
Reason being, I have left this bulla intact. See this. Now, once I elevate, we'll show you something at the skull base. Correct.
I think this intact bulla technique was propagated by Dr. Sethi from Singapore.
100%. I always remember he propagated lot many concepts of sinus surgery in our country by a number of workshops, almost more than a decade before,
Yes.
almost for 2 decades. See this.
Yes.
This I am taking out. That is the bulla, and that is the upper attachment of the bulla. Can you see?
Yes.
There. Now see. Because this
Zero
was
degree.
distorted. This was distorted.
Yes, yes, this was distorted. It also like that. So this is bulla, na? This is part of bulla.
it. Yes.
Your some extra it might
There
say.
is some bone in it. So it comes. See this. Lot of fungal disease around. I told you in this region. From CT scan. Lot of fungal disease here.
Most important question That's not me.
See this fungus.
Anterior model set. These are all part of anterior model set.
See, lot of fungal disease behind.
तो सर posterior sphenoid में
Yeah, I am going toward the anterothymoidal artery territory. See this.
Yes. This is all part of
That is the upper attachment of the
bulla. Upper attachment of bulla.
yes. See how much of the fungus around. This is still the bony shell.
बुल्ला ही मिलेगा याद रखो
Find out.
then we make it multiple cell
Yes. See so much of the fungus removed. Give me a through cut. Now I will take this through cut to take away all these bony openings. That is the upper attachment of the bulla. See what I have broken. This upper attachment of the bulla to the skull base. पकड़ नहीं रही. See, this is the upper attachment of the bulla to the skull base. See this? All upper attachment of the bulla to the skull base. Through biting. Now, I will look at the roof after removing this bony remnants. See all these bony remnants. This is through biting. See, it cuts like butter. This is Karl Stoll's through biting. My favorite. Flushing with the lamina laterally. All these cells with so much of mucosal disease. True biting and microdebrider is preferred at all these places because it is mucosal preserving. You don't pull anything, you cut. You pull anything, can lead to problems. Can make the mucosa, pull the mucosa, and that is the region of the enteroethmoidal artery. Let me uncover this completely. Yes. Can you see this beaking of the orbit here? Hello.
Yes, dear.
This is the beaking of the orbit.
Yes.
And 3 here, the vessel is going towards the lateral lamella.
Lateral.
Reverse.
The anterior
And this is always caudal to the supraorbital recess. Always.
Always. Yes.
This was our supraorbital recess. And immediately caudal to that is
Anteroethmoidal artery.
Yes, exit. I am using my reverse again.
यहाँ पे ध्यान देना स्कोप जो है ना
See, this is supraorbital recess, very close up view.
पिक्चर नहीं देता ठीक है कैमरा तो और भी नहीं पिक्चर देगा जैसे दिखाई पड़े वैसे कुछ नहीं
So flush all these septations at the level of the skull base. If you leave these septations, this becomes avascular bones and can invite infection. Always flush them and leave everything covered with mucosa. More and more mucosa preserving. See that?
Yes.
That is complete, enteroethmoidal skull base work. See, so far, this work now I have done with the 70-degree.
Oh, it's wonderful.
Wash. Wash. This is all done with 70-degree mob there. So you don't have to terrify yourself with a vessel or anything as long as you have gone through the CT scan. You know where what is related to, and this is the final picture of, see that wide opening. This is supraorbital cell.
Yes.
That is the
Supraorbital cell or supraorbital recess? This is supraorbital cell, no?
cell, quite deep. It is not a shallow recess. Had this been shallow, we would call it recess. And that is your, you can see the vessel running if you want to see.
Yes.
Can you see?
अब काट के मत दिखा देना भाई. यहाँ palpitation हो रहा है लोगों को.
Nothing will happen. Only thing, it should not be transected close to the orbital exit. Reverse. Don't worry about. If it is transected in the middle of the course, see this? Nothing will happen. You can just simply bipolarize. Because we intentionally transected many a time in a skull-based surgery, in transcribiform approach.
Yes, you have to transect it. There is no way out.
Now it is very clear. So now let's change to switch over to 0 degree now. There has always been discussion about the final required size of the frontal sinus opening. There is no final size in terms of millimeters or centimeters.
Yes.
It should be flush to the limits. That's it. Whatever size, final size will be dictated by the size
the
given by that size of
anatomical
that
situation.
anatomy of that particular person. See that?
Yes, yes.
The frontal above with the 0 degree. That's the Porcelain model cell where we remove the fungus from. That's
Yes,
the
small
additional
fungal wall
artery.
right there.
ये देखो, cover it.
एक और
And now
इसके अंदर
the
में
work posteriorly, that is very, very crucial. And in this patient,
मिल
it is-
दे रहा है, ये तुम्हारा network
it is very important. Now, before going behind, what I will do,
और हो सकता
I
है
will
deep
define a
जाना हो.
landmark. See, I will define a landmark here at the medial orbital angle. And that is the orbital floor.
पोस्टर में मेरी वॉल दिखाई पड़ रहा है. ठीक है. देखो उसका पीछे जो एक्सटेंशन मीडिया जा रहा है ना, इसको वो लोग पोस्टेरो मीडियली कर सकते हैं. या ये जा रहा नहीं. ठीक है, ऐसे करके. ठीक है, ये तुमको वही होगा अपर लिमिट ऑफ.
What I am trying to define here is the orbital floor.
That is the limit of the same that muscular telescope. Most of the उस लेवल पे उसी लेवल पे मोस्ट ऑफ द टाइम रहता है. लेकिन याद रखिए ना, these are related anatomy है ना, मोस्ट ऑफ द टाइम विजिट बट नॉट ऑलवेज. ठीक है, तो इस अगर याद करो कि इसी के सामने ही हुई होगा, मैं विल डू द डैमेज. ठीक है, वो नहीं करना कभी भी नहीं. वहां पे भाई सतीश जन बताया था किसी लेवल पे होगा.
See now,
मोस्ट ऑफ द
what I
टाइम
am trying to define here is the orbital floor. Orbital
The
floor is a
roof.
wonderful landmark.
orbital roof. Orbital
Orbital
floor. Sorry,
floor.
sir, yes, orbital floor.
Or
Orbital
maxillary sinus roof.
maxillary sinus roof.
See, that is the level. And that is a level important for many regions
Yes.
when you work behind. Because when you go behind, our concern is not to accidentally enter into the sphenoid sinus and damage the structures there. So this landmarks helps you all the time. how to go behind at what level. See this. That is the orbital floor. There was some osteotic bone which I have removed. That is your medial wall of the orbit. You can see. See this? Completely widened for free flow of steroids, topical steroids later on. See this. Now, where to enter into the ground lamella for the postethmoid and at what level you look for the sphenoidotomy. For these 2 points, this orbital floor landmark is crucial. So first of all, where to enter? And see, this is middle turbinate. See this?
Yes, very
The
clear.
best, this is a very good landmark. Always respect it, and the best respect for that is stay away from it.
Yes.
Stay away from it. We never bothered about the middle turbinate all the time. We kept in view, but did nothing to it. Now see, I'm entering into the postethmoids here at this point of the level of the orbital floor. See this.
यही था बेसल लैमेला, यही अभी जो कटा ना, यही होगा बेसल लैमेला, यही
See? And go medially. Stay medially. Stay medially here. See this? All this distorted bone. This is your superior turbinate. Can you see?
Yes, yes, very clear.
And medial to that is the nasal septum. See, this is nasal septum.
That is तुम्हारा जो
See, 2 important anatomies here. Before completing my postethmoidal work, I know this postethmoidal cell is pushed behind. I may get disoriented while entering into the sphenoid sinus if I am not aware of it. What is the safest entry to the sphenoid? At the level of orbital floor, go between the middle turbinate and the septum. See this?
Yes.
This cell has gone far behind. See this? Cut. Keep an eye this level of the orbital floor and see the septum there medially. Middle turbinate undisturbed.
Yes. You can remove the remnant of the superior turbinate in the lower third. Now, where to enter for the sphenoid sinus and why to look for the sphenoid first without completing the postethmoidectomy? The reason is I have to make a medial entry into the sphenoid sinus through the ostium. Yes.
And this level of the ostium is always anterior to the critical structures.
Yes.
Whatever optic, carotid, whatever malformation there. See now the instrument I am using, suction periosteum elevator. Now, what is the value of this landmark? If I go above this level, suppose, and look for the sphenoid ostium there, sphenoid ostium is never along the floor.
Yes.
It is more closer to the roof as compared to the floor.
Floor, yes.
If I don't take this landmark in consideration and look for the ostium up there, I can enter into the plenum sphenoidal
Yes.
and can get a CSF leak. That's a disaster. So, see this level. Stay in this level or below and slide. See this. Slide along the
Septum.
septum.
Yes.
See this.
Yes.
Slide along the septum and I am in the sphenoid sinus. Can you see?
Yes, very clear.
That is sphenoid. See that?
Yes, yes, yes.
Glide along the septum. That is most important. Don't glide along the turbinate.
Glide. Yes, glide. You better
Glide.
go to
Glide along the septum in the plane of the maxillary line. See that?
Yes.
Having seen the ostium now, Now, and see the ostium and the interior of the sphenoid.
Yes.
Having
True,
seen
sir.
them now, you can remove anything anterior to it. Now you got your level. See my point? I can now remove anything anterior to it. See the
एनाटॉमी
cell.
सेल ना तुम्हारा जो ओनोडी सेल था ना पीछे उसके ऊपर से ज्यादा साइड वाला क्या ना
Now my job has become much easier.
दिस इज नॉट पार्ट ऑफ स्पिनॉइड अरे ये जो सामने से कोई हट रहा है ना ये
Now my job has become much easier.
यस
See, that is the post-model cell.
यस 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 दैट इज पॉसिबल
It's on CT scan.
is trying to remove the bone बंदे ठीक है
And now mucosa I can divide. If you pull the mucosa, that will give raw area.
पूरी एनाटॉमी कर ले तो सीटी स्कैन से ना दिस इज पार्ट ऑफ पोस्टेरियर साइनस ठीक
See,
है
that is the bone which was extending behind. Remember?
lateral to the sphenoid side
And frontal, the sphenoid sinus is
laterally था ना
the
तुम्हारा
small sinus on this side. We remember.
बस वो नोडी सेल ले वाला ऐसे ही मुझे प्रॉब्लम है
See now? Things are becoming more and more clearer now.
बस
See, maxillary sinus, this was the posterior model cell which was pushed behind. And see medially the frontal sinus. Sphenoid sinus. See all sinuses in one view. Give me, Harrison. Now I will punch out and widen this opening. You can use Stemberger punch.
Hello.
You can use Harrison punch. You can use a side biter. Side biter means a side through cut biter.
which
Or you
instrument do you which instrument you prefer
Anything
Punch.
depending upon the,
availability
Hello.
here let me show you. I am using a Harrison. You can use anything. You can even use a drill if it is too thick a bone.
no
But the Stemberger punch is also a good alternative. See the opposite sphenoid sinus here.
yes
Can you see?
yes 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 yes
See the opposite one.
yes
Hello.
Because this sinus was very slow. And see, I prefer a medial opening. When you work in the sphenoid, stay as medial as possible.
ये कॉस सेल नीचे में भी उसके नीचे यहाँ पे ये क्या था ये
See
है
the sphenoid below, the
Yes.
smaller one.
यस 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 हो गया ना तो पूरी क्लियर ना
Hello.
yeah
Can you see very clear?
yes very what is that rounded projection there in the opposite sphenoid
Yeah, I will remove this. This is the anterior part of the anterior wall. And widen. See how the sphenoid was pushed by the posterior cell. That's what I was again and again telling you during the CT scan. I knew from the CT scan how it is going to behave. Now see the beautiful sphenoid from this side. Okay, there. See the sphenoid on this side
yes
or the sphenoid on the other side? Is that very clear or not?
very clear no doubt
That is opposite side And this side has become so small
नहीं यार,
because of that cell that we knew from CT scan also earlier. And now see all walls flushed, completely flushed. So that completes our sinus surgery on this side. We'll just give it a complete wash, flush it. Our next case is induced, probably. And that's a hemithyroidectomy. I suppose. So one table will keep endoscopic cases, other table for other cases. See, everywhere it is mucosalized. Can you see?
Yes, yes, very nice.
Now, what we have achieved, you see in your office, in your OPD, with 0 degree, and you can see all sinuses in front of you.
Yes, wonderful.
No,
Super.
no need to get CT scan or anything done for this. At the same time, it gives you opportunity for the topicals to push
Each
inside.
everywhere.
Yes. That is more important a goal over there. So this kind of work if done, what all is needed for the patient for the future is to treat for allergy by means of immunotherapy, topical steroids, whatever. Even suppose in the worst of the scenario, patient lost for the follow-up and doesn't do anything and develops the polyp again because of the same underlying pathophysiology. Since the bone work is completely done, this is full house test. We have already reached to the limits. See everywhere?
Yes, yes.
The skull base behind, the orbit laterally, the skull base upper medially, everywhere. Everywhere we have reached to the limits.
Satish, Dr.
Yes.
Satish, please show some important structure of the sphenoid sinus.
Yes. So what I was trying to say, since we have reached to the limits everywhere,
Yes.
in the worst scenario, the patient lost to follow-up, doesn't do anything and develops polyp.
Just
You can
use.
just spray and debride the polyps and again start the topical steroid. That's it.
Yes.
A patient will never require a formal sinus surgery again.
Yes.
So nothing is already flushed to the limits. Nothing is left for the future sinus surgeon to do any kind of bone work or anything.
Hmm?
No
Yeah.
bone work is left for the
This is
future surgeon.
comprehensive. Comprehensive first.
Now see inside the sphenoid.
Some important structures.
Yeah, here, since this side of the sphenoid is not very big,
Yes.
what you see, the intersinus septum is eccentric coming to this side.
Yes.
This is the clival recess.
Okay.
This is the sala. And above here should be the optic, which is hidden over here. And we don't intend to see that.
And what is the vertical structure going in the right sphenoid? Right. In the right, there's a vertical structure.
Yeah, this is the lateral wall, part of the lateral. Since it is very small, the structures are not prominent. We will see in the next cases where we see a big sphenoid, you will see all structures there. More than pneumatized sphenoid,
Better than
more prominent would be the intrasphenoidal structures. So that's the final picture.
Yes, wonderful.
So we leave it here. We'll pack it with the same aerosol pieces, remove them after a day or two, and then topical steroid is started. Now this patient, what all this patient requires is a topical steroid, nothing else. This mucosa, most of the mucosa is preserved on the wall. See,
Yes.
if you try to
Yeah.
remove the mucosa, you have removed the mucosa. Why
Will
this
you-
surgery is called functional endoscopic sinus surgery? Because this function is served by the mucosa, that is mucociliary clearance.
Will you do septoplasty in this case because of DNS? For
Not really.
DNS?
Not really. The reason being, I don't, this is a strict unilateral disease. I don't want to implant anything on the opposite side at this stage. It is rather recommended not to do any septoterminoplasty for the opposite side in these strict unilateral AFRS. Secondly, what I was telling, if I happen to remove the mucosa, suppose
Sometimes,
mucociliary, yes,
sometimes I have seen you removing the middle turbinate in cases of AFRS.
yes.
So what is that indication? When do you remove the whole of the middle
This middle
turbinate?
turbinate was behaving like a good boy.
Good boy, yes.
It was already
So
placed
good.
close
Good
to
boy
the
should never be
septum.
punished.
It was not a floppy one. What we want for the future, for this surgery to remain successful, a topical should penetrate deep into the sinuses uninhibited. If your turbinate is floppy and it becomes a sort of obstruction, or it can become in future, for the topicals to penetrate, better you do a partial resection. Because in any case, our goal is to make the topicals penetrating deep into the sinus. Then only in that situation you can remove it. Secondly, what I was telling, that mucosa, all this mucosa should be completely preserved as much as possible. Because if you don't preserve the mucosa, the raw bone will be uh, inviting the crusting, infection, lot many things, and then it will heal by secondary intention, and then the function will not be served. So it will all be a problem, and then it will not be fess, it will be mess.
Mess.
So
Question?
preservation of the, mucosa is the key for a better outcome, successful outcome. And
Nanoplasty surgeon से पूछे पड़ेगा.
Excellent demonstration, Dr. Satish, as usual.
thank you,
Hello,
sir.
Dr. Satish. Hello.
Yes, sir.
Dr. Satish,
Yes, sir.
it was an excellent demonstration as usual. You make it look so simple to do, and it's really very simple.
Thank you,
Really
sir.
very
Thank you.
simple.
It is not difficult, sir, if you follow the
Yeah, in your hand.
Satish, Dr. Satish.
Ashwini, it
There is
is
a
in the hand
there is a
of Dr.
question from
Satish.
audience, boss. There is a question from audience. Dr. Satish,
Yes, sir.
it is not related to face, है ना? But what is the lower limit of septoplasty in today's scenario? Today's
What is the lower limit means?
lower limit of age for
Age,
septop.
see, age is not a bar. As far as you do in younger population, a limited work, a pure strict septoplasty, not SMR. So if obstruction is the indication, we have done even in 4-5-year-old children for obstruction. But a limited septoplasty, not a extensive work, or not SMR for that matter.
But most of the time, people say that we are doing septoplasty, but actually they are doing SMR. This is the real situation, है ना?
But
People
if
start with
obstruction is the indication,
people
you have to
start
clear
people
obstruction.
start with septoplasty and it gets ultimately converted into SMR.
Yeah, but in children, doing SMR can be harmful, because the ossification center in the septum in children, particularly in the upper part, can be something hazardous for the rest of the growth, and it should be avoided. But a limited septoplasty, correcting only deflected part and replacing it back, can be a good option to open up the airway.
Okay.
So, any question before we move on to the next one?
No, sir.
Hello.
Yes, sir.
Yes, sir. Any other question before we move on?
Then actually, there are a lot of PG students here, and they want some question to be asked from you, and they will try to answer it.
Okay, you want me to ask the question?
You ask the question, and they will answer it.
Okay. So my first question, it's not about the simple or difficult. What is the indication for surgery
Only for PGs.
only for PGs? How can you clinically decide when this patient requires surgery of a sinusitis case with a CT scan and endoscopy picture in your hand? When to go in for surgery and when to go in for conservative management? What is the, dividing line? How do you decide in a clinical practice? Because ultimately, you being a clinician is going to take a call whether this patient will require surgery or not. Because not understanding this fact is a problem. Not many patients requiring surgery are being unnecessarily operated, and many of these patients who require surgery as an answer are being unnecessarily treated with steroid or antibiotics.
Good morning, sir. It's Dr. Navles from the DMC final year, sir. MSc
Yes.
final year. Yes, sir. So basically, if the patient is having nasal obstruction, symptoms of nasal obstruction, then conservative management will not suffice. That in that case, we would like to do surgery, sir.
We are talking of sinusitis, not DNS. So, on endoscopy, what you are talking about nasal obstruction, what is the endoscopic finding?
There will be, sir, inflamed mucosa, sir. So it may lead to obstructive symptoms, sir. And there will be heaviness in the maxillary area because of the closure of the osteometal complex.
Our sinus surgeries aim to improve the ventilation and drainage of the sinuses. At the same time, removing the inflammatory load of the sinuses. At the same time, allowing the topical steroid to penetrate into the sinuses. You said the patient has obstruction, how sinus surgery is going to help him with congestion. Sinus surgery is not aimed to relieve congestion or to improve the nasal obstruction unless there are polyps obstructing the nasal cavity. That's why I asked, what is the nasal endoscopy finding?
Yes, sir. Thank you, sir.
Anybody else? So, what I mean to say, why I asked this question? We should be very clear in our mind which patient requires sinus surgery and which requires conservative management. The reason being, those require sinus surgery as an answer should not be unnecessarily treated by antibiotics, steroid or XYZ drugs.
Sir, excuse me, sir. Sir, does inspissated thickened mucus secretion refractory to medical treatment is also an indication of surgery?
See, surgery is not based only on the clinical findings. Yes, clinical findings are important. At the
Yes,
same time, you have to corroborate with endoscopy and CT scan.
Okay, sir.
Now, tell me, patient is yours, findings are with you. What are your findings to take a call for sinus surgery? All three.
Sir, one will be, sir, inspissated thickened mucus secretion, collection of eosinophilic mucin.
On endoscopy.
Yeah, sir. Yes, sir. On endoscopy and radiologically also, sir, secretion or pacification involving maxillary sinus and all.
Okay. With no polyps?
Sir, with polypoidal, sir, polyposis changes.
Polyps in the middle meatus or not?
Yes, sir.
And patient symptomatology.
Sir, patient symptoms will be like, sir, nasal obstruction and sir, heaviness in the maxillary and antrum area, maxillary area.
See now, let me elaborate your point.
Okay, sir.
All these things you have mentioned is important. Now, how to take a call? Such patient who has a opacification, some eosinophil secretions, on endoscopic, some polyposis, how to take a call for surgery? If such patient is coming to me, and if I give him a course of oral steroid for say 2 weeks,
Yes.
he'll be relieved of all his symptoms.
So, excuse me, sir. Which one will which steroid will prefer?
Yeah, prednisolone, simple.
Prednisone. Okay, sir.
So if that patient, your patient, what you have seen and what you have recommended surgery,
Yes, sir.
if that patient happens to come to me with all these findings,
Okay,
with
sir.
minimal polyposis, some opacification and some symptoms,
Hmm.
if I happen to give him a course of oral steroid, an oral steroid will definitely improve him like anything.
Yes, sir.
And he'll be grateful to me and he'll go back to you and curse you that you are unnecessarily operating on those patients. That doctor is much better. He's treated with the drugs only. He's too good. How will you deal with him? See, if I give oral steroid and the oral steroid tackle the inflammatory load and he becomes symptom free,
Okay,
that
sir.
is not the final answer. My take for the surgery will come if the patient becomes symptom free with the oral steroids and then you switch on to the topical steroids. Now, if his inflammatory load is less and can be tackled with the topical steroids only, you don't need surgery. If he again becomes symptomatic, if the again problem reverts and requires or needs oral steroid against to control his symptoms, you can't give oral steroids again and again. So the patient for the surgery, the candidate for the surgery would be the one who will need or who requires oral steroids again and again in say 2 to 3 months. A patient needing oral steroids again and again to control his symptoms is the candidate for sinus surgery, so that you can convert the need to from oral steroid to topical steroid.
Okay, sir.
That is the indication.
Thank
It's
you,
not
sir.
that first time you see and
Yes,
advise
sir.
surgery.
Okay, sir. Thank you, sir.
Sir, good afternoon, sir. Sir, in the previous surgery, sir, yes, sir, you removed the debris, fungal debris from all the sinuses. But is there any role of septoplasty after removing the debris, or the septum will come to this normal position after removing the these?
Yeah, you can expect a little bit,
Yes, sir.
but see, once you treat the inflammation, now the overall inflammatory load has been reduced.
Yes, sir.
Now the topicals will penetrate better and the inflammatory condition will become better.
Yes, sir. So for how long we should give the topical steroids, sir?
That depends upon the pathology, the allergic
Yes, sir.
reaction.
The
That
reactions.
you have to monitor. You can start with the topical budesonide, then as the healing, takes over in
Yes.
6 to 8 weeks, you
Yes.
can keep reducing the doses,
Yes, sir.
the strength of the topical, the doses and frequency, and keep a close monitoring on the mucosa with a 0 degree.
Oh, sir.
If the mucosa remains good with
Yes.
the even after reducing the steroid, you can keep reducing.
Yes.
The moment symptoms come, you have to increase the dose. See, now the final regulation will be with a topical steroid without the need of oral steroid. That is the beauty which we have achieved through this surgery. That's why we have operated upon this patient. That is one of the most important goal now, to make the topical steroid penetration.